Good morning. My name is Jeff Puretz. I'm the chair of the board of the Charles E. Smith Life Communities. Thank you for joining us today for the third and last session of the 11th annual Sara and Samuel J. Lessans Healthcare Symposium. This final session will focus on our journey through the pandemic. I would like to recognize and thank our partners, Suburban Hospital, a member of Johns Hopkins Medicine. We are so glad to have them with us as partners in our planning of this important event. I would like to welcome and recognize Drs. Stuart and Ellen Lessans for their continued support of this program, named for Stuart's parents, Sara and Samuel Lessans. And finally, I would also like to thank our sponsors, Optum and Minkoff Company, for their support and dedication. I wish to recognize HFAM, the Health Facilities Association of Maryland, who make it possible for us to offer continuing education credit for social workers and nursing home administrators. Those attending today will receive 1.5 hours of continuing education credit. We are also approved by the Maryland Nursing Association to offer 1.5 hours of continuing education credit for nurses. Details about these continuing education credits are on our website. I would also like to acknowledge and thank our Symposium Planning Committee. This group begins meeting almost a year in advance. Their dedication, support, and expertise are what make this event such a success. And finally, I wish to thank the Charles E. Smith Life Communities Director of Community Engagement, Robin Lerner. Thank you very much. Now, I would like to welcome our President and Chief Executive Officer, Bruce Lederman.
Hello, I am Bruce Lederman, and as President and CEO of Charles E. Smith Life Communities, it is my pleasure to welcome you to the 11th annual Sara and Samuel J. Lessans Healthcare Symposium. We are honored to present this event every year to provide education on relevant topics impacting the lives of older adults, and we are very glad you are able to join us virtually. I would like to recognize and thank Drs. Ellen and Stuart Lessans, who make this symposium possible, in loving memory of Stuart's parents, Sara and Samuel J. Lessans. For over 100 years at Charles E. Smith Life Communities, we have remained committed to providing quality care and meaningful life experiences for older adults. On any given day, those we serve are living their best lives on our campus in Rockville, Maryland, just outside Washington, D.C. Among the lifestyle options we offer for 1,100 older adults are at Revitz House and Ringhouse Residences, where we provide vibrant and healthy aging in apartment-style living. At Landau House and Cone Rosen House, where assisted living is available and additional memory care support for those who are living with cognitive decline. And for those who require a short stay, our therapy and medical teams are available at the Warren Slavin Post-Acute Care Center, located in the Hebrew Home of Greater Washington, and where we also provide long-term nursing care. Thank you again for attending the symposium, and to learn more about CESLC, please visit our website at smithlifecommunities.org. Thank you.
Good morning, everyone. My name is Kathleen McGinnis. I'm a certified dementia practitioner and director of community relations for Smith Life Home Care. Smith Life Home Care is a partner company affiliated with Charles E. Smith Life Communities. We are honored to be a part of their community for more than 20 years. Of course, we'd like to add our thanks to the Symposium Planning Committee for their hard work and community education. Now for a brief overview of Smith Life Home Care. For over 20 years, Smith Life Home Care has been providing as much or as little care as needed to support families aging in place throughout the Charles E. Smith Life Communities campus, Montgomery County, and recently, Washington, D.C. We feature personal care and health care support, lifestyle services, short-term care, long-term care, 24/7 care, and safe discharge services from all local area hospitals. As an added value for our families for better communication, we offer the Family Room portal online so you can communicate with your caregivers on a daily basis. Free home safety inspection, 24/7 phone line, and we're an award-winning company voted best in home care by the Jewish Weekly. If you have any questions or would like to start service, please consider calling us at 301-816-5020 or go to www.smithlifehomecare.com. Thank you for joining us today.
Thank you, Kathleen. Our last session, Our Journey Through the Pandemic, features 3 speakers. Dr. Alyssa Girl-Pires, MD, Senior Vice President of Medical Affairs, Chief Medical Officer, Medical Director of Chelsea Smith Life Communities. Dr. Sonia Kasba, Hospital Epidemiologist, Hospitalist Physician for Johns Hopkins Community Physicians Suburban Hospitalist Group. Dr. Isha Misra, MD, Hospitalist, Johns Hopkins Community Physicians at Suburban Hospital. Their bios have been included on the Chelsea Smith Life Communities website. Thank you to the 3 of you for joining us today. First, we will hear from Dr. Gill.
Good morning, everyone, and thank you, Jeff, for that lovely introduction. Thank you all for taking some time out of your busy day today to join us for our 11th Sara and Samuel Lessans Healthcare Symposium. This is one of my favorite committees to work on throughout the year. Our team does a fabulous job every year putting this together, and we hope that you will find it informative and also enjoyable. I have to say that putting this deck together over the last couple of weeks was an experience that I would describe as surreal and quite emotional. Having to relive the many events and markers of the COVID-19 pandemic that lasted over 1 year for us was unlike anything I've ever experienced in my medical career thus far. Really, it felt like a roller coaster every day, and we just were not able to get off that ride. I wish to give a special thanks to our CESLC team who worked hard to execute all 3 sessions of this virtual symposium, first time doing it virtual. And thank you to our CESLC clinical and operations teams who worked tirelessly during all of 2020 to keep our residents and colleagues safe. A very special thank you to our senior leadership team led by our CEO and President, Bruce Lederman, who working together as one CESLC accomplished countless projects that made us stand out as leaders in our space. And lastly, I want to give a very special thank you and a personal thank you to Ed Van Kootren, who was my partner in the COVID Command Center for over 1 year, whose retirement lasted all of 1 week before he stepped up as special projects consultant and helped guide us through all of our COVID-19 work, keeping me sane through it all. Thank you, Ed. And now I hope you will enjoy our presentation, COVID-19 Pandemic, Mental Health Effects on Older Adults and Their Healthcare Providers, Our Journey Through the Pandemic. We can skip over the presenters. Jeff already introduced us. I have no financial interests or relationships to disclose. I want to go through the 3 learning objectives for today's sessions. Number 1, the attendees will be able to describe key events that shaped medical and clinical decisions throughout the COVID-19 pandemic as they related to and affected patient care in the acute care setting. In this case, Suburban Hospital at Johns Hopkins Medicine Hospital, our primary partner at Charles E. Smith Life Communities. Learning objective number 2, attendees will be able to describe the effects that the COVID-19 pandemic had on the mental health of older adults, specifically those living in an institutional setting such as a skilled nursing facility and an assisted living facility. And lastly, our 3rd objective, the attendees will be able to describe how governmental regulations, guidances, and directives from the Centers for Disease Control, the Centers for Medicare and Medicaid Services, and Maryland Department of Health informed the strategies and operations used by Suburban Hospital and the Charles E. Smith Life Communities to care for their respective patients and residents and ensure the safety during the COVID-19 pandemic. All right, let's get into our journey. So I provided for you here a timeline of key events that happened at Charles E. Smith Life Communities, better known to the greater community as Hebrew Home of Greater Washington, which is our skilled nursing facility, throughout all of 2020 and part of 2021. I broke the presentation up into 5 phases, each strategically dated with key events that happened around these times. We'll start with pre-phase 1, which was the preparation for the pandemic, which started at the end of January prior to the country and the world announcing that this was a pandemic. Phase 1 is what I call the first wave of the pandemic, end of March through mid of July. Phase 2 was the summer, middle of July through October and part of the fall. And phase 3 is our second wave, October 21 through January 1st. And then we'll conclude with our last phase, which was our vaccinations, which for us began on January 2nd and are still ongoing. I like this slide. Bruce had actually included this in one of our presentations that we gave to our quality board committee. And I like it because being around for 111 years, Charles E. Smith Life Communities has been through many crises and many rodeos. And so it was not our first time at the rodeo. However, it was our first time having to deal with a pandemic like the rest of the world was dealing with. So we'll take you through the rodeo. Next slide. From the beginning, we were very mindful to align our mission to the moment. And the mission of Charles E. Smith Life Communities is to deliver quality care and meaningful life experiences to older adults with dignity and compassion rooted in Jewish values. Our pandemic response then, our first priority at Charles E. Smith Life Communities was to protect the health and well-being of those that we serve and also our team. There were numerous stakeholders and constituents, as you can see here. There were many organizations and individuals who influenced our policies and procedures. Some influencers, those that you see in blue, also had regulatory oversight functions over our skilled nursing facility and our assisted living facility. Many of them became resources later on, in addition to their regulatory oversight functions. I won't go into all of them that you see there. A lot of them are acronyms. Next slide. In addition to those stakeholders, we also had other influencers like the media, like our Healthcare Facilities Association of Maryland, like our team members, our associates, AMDA, the American Medical Directors Association, which is putting out a lot of guidance on how nursing homes should direct their care and keep their residents safe. And then also our customers, which were our residents and their families, which obviously were very influential in how we strategized and operationalized the pandemic response. So we start here with pre-phase 1, which is the end of January through the end of March. So during these 2 months, I wanted to remind you what was going on in our world. So our environmental factors were, we had uncertain PPE supply. As you know, this was all over the media, healthcare workers struggling to keep themselves safe from a virus that we had no clue about and really didn't know how it was going to affect us and our patients. Uncertain staffing, a lot of anxieties and fears causing staff to resign and leave the profession. Hospital capacities were strained. We had lack of infection control information about this virus. We had lack of information on conserving PPE. We had lack of initial coordinated response from stakeholders. We had lack of testing. You will remember there was no testing available. We had lack of treatment and a ton of fear and anxiety amongst healthcare workers dealing with the unknown and what was to come in the future. So our principles of action remain to align our mission to the moment. We treated all our individual sectors as one campus. We have two independent living facilities on campus with approximately 500 residents. We have an assisted living residence on campus. We have a nursing home on campus with over 400 patients and residents. So we treated everything as one. And so that over 1,000 residents were kept in mind as we strategized and went through our response to the pandemic. Our resources would be available to secure supplies and personnel. We knew that our team was our most valuable asset, and without our team, we would not be able to get through this pandemic. Communication and transparency were critical, and we made the best decisions with the information that we had available. We deployed the technology we had, and of course, we documented our work from day one. So here was our response. We believed that early planning was key. Response plans were quickly operationalized. Our task teams were established. We educated our teams and customers from the beginning. We developed communication pathways. Our PPE needs and supply chains were quickly assessed, and we quickly developed and deployed new policies and procedures to address this pandemic. I added this picture last minute after I had already submitted my deck, and I was cleaning out my office, and I have a whole section about COVID-19. These were just two of the binders that held very important documents that were released from the CDC, the CMS, and MDH almost on a daily basis, if not on a weekly basis. Things were changing very, very, very rapidly. I'd say over 90% of our work is documented electronically, so you don't see it here. But these were nostalgic for me, and I'll keep them forever. But these were two of the binders that helped guide our work. Next slide. So phase one, we now are into the spring. End of March through July, the government agencies were focused still on PPE shortages and price gouging for PPE. I think at one point, Ed would know best, but I think we were paying up to $5 per gown, which is extremely high. We had testing limitations. We had changing regulatory requirements, changes that were coming very, very frequently and hard to keep up with. We had the virulence of the viral spread, which now we were starting to see this was not something like the influenza that we could control quickly. We had increasing number of cases, and we had overburdened government resources. These are some of the headlines that I included just to take everybody back and remind us what was happening in our country at this time. You'll see that around March, coronavirus cluster near Seattle, Washington highlights the vulnerability of nursing homes. That was the first outbreak identified in Seattle, Washington. Coronavirus death in Maryland nursing homes rises to 5. This was in March. 65 sick as coronavirus outbreak reaches Maryland nursing homes. Nursing home deaths rise in Maryland with tests and protective gear being scarce. Everybody was experiencing the same kind of nightmare around this time. Next slide. Abandoned nursing homes continue to face critical supply and staff shortages as COVID-19 toll has mounted. Nursing homes run short of COVID-19 protective gear as federal response falters. Next slide. Okay, so here's where our journey really took off. The week of May 18th, we did universal testing of this many people on our campus. This included our nursing home, Hebrew Home of Greater Washington, our assisted living Landau House, and our memory-specific assisted living Cohen Rosen House. So on one day, actually it wasn't during the week, it was in one day, we tested 459 residents. Of those, 9 were identified as positive, and this is with PCR test, which was highly reliable. We tested 930 staff members, 6 of which tested positive, and you see there our positivity rate amongst residents at that time was almost 2%, and staff was 0.6%. The Maryland 7-day positivity rate at this time, this week, was 15 up to 15.4%, which became very scary very fast. I put this slide here because this is a day we will never forget on campus. This was May 18th, and this is when we did all that universal testing in one day. Our teams all banded together. Who you see there are our clinical team managers, also known as our nurse managers. Everyone stepped up and helped test all those residents and all those team members. In one day, we were able to get all the COVID-19 testing done. We couldn't really recognize each other with double masks, goggles, and face shields, so I put my name on my gown. So the same day, actually May 18th, we had a surprise visit from the Disaster Medical Assistance Team. This was a team sent by the government which was sent to inspect and all nursing homes policies and procedures and see how nursing homes were handling the COVID-19 pandemic. If you recall, this is after what had happened in New York, when a lot of nursing homes patients were dying, and they believed that the outbreak was not being properly controlled and managed in nursing homes. And so nursing homes became the focus of scrutiny, and Maryland decided that it would be important for government resources to show up and make sure that our nursing homes were having things under control. They toured both our COVID recovery units, which we had built at this time, and we did quite well. They commended us for the great work we had done up to date. This was on May 18th. There's a couple more pictures. So this was the May 18th date, where we tested 1,389 people on that one day, and also the DMAT team showed up. That's them there when they showed up on campus. And there's Brenda Rice, our VP of Operations, with some of our team members who had conducted the testing over that day. I'm going to skip over this slide. These were just some of the government agencies that had some influence into how we handled operations and strategized for future management of the pandemic. Next slide. And here we start our timeline of significant events. This was many, many slides, but I condensed them into what I felt were the most outstanding events that happened during this time. So as I mentioned earlier, January 27th, we established a COVID-19 task force at the Hebrew home where the command center was located. The end of February, on the 29th, the first long-term care outbreak was announced in Kirkland, Washington at a nursing home, with many deaths that ensued from there. On March 3rd, we launched our COVID-19 response page on our website so that our families and our residents had a place to go and communicate with us. On March 8th, our emergency leadership team was created to lead strategic operations. Next slide. March 9th, virtual calls for residents and their families began, because we knew we would have to close down at some point and not let the community into our residences in order to keep our residents safe. By March 11th, we announced that no visitations were permitted on our campus. And 2 days later, we introduced a new electronic screening tool at the entrances of all our buildings for anyone coming into the buildings. Next slide. By March 30th, we had our first case identified at a Hebrew home. And remember, this is before the universal testing occurred in May. So by March 30th, we were off to the races. April 3rd, all our doctors were up on a telemedicine platform in case they got sick and they were not able to see their patients. We were able to work through telemedicine to still take care of our patients. We also instituted Beekeeper, which is a social media platform to support communication with our teams internally. April 6th, we began virtual visits for our residents, realizing that this was probably not going to end anytime soon, and that it would take an emotional toll on our residents who are dependent on their family visits and on their friends' visits in order to maintain their mental well-being. On April 12th, we opened our first COVID-19 recovery unit. April 20th, we had an epidemiologist from the Maryland Department of Health conduct an on-site visit. They spent most of the day there reviewing our policies and procedures with the key team that was involved in this. And they also toured our COVID recovery units. We actually did very well. They commended us for following all the infection control policies and protocols that they had wanted us to put in place. And they also remarked on the layout and design of the COVID recovery units that we had built for our COVID-19 patients. 2 days later, we began weekly town hall meetings in mid-April so that we would inform our residents and families weekly of what was happening in our residences and what was happening with their loved ones. We also began bi-weekly town hall meetings at the assisted living and the independent living residences for the residents and their families. By mid-May, our first 6 residents to contract COVID-19 virus had successfully recovered from our COVID recovery unit and returned to their home unit. And there's a picture of our team, which was designated to work on the COVID recovery units. This was, of course, taken after we had closed our COVID recovery units and recovered from the pandemic. That is why they're standing so close together. But that's our brave team of nurses and physicians and dietitians and therapists and everybody else who were designated to work on COVID recovery units and nowhere else in our residences. Next slide. So I take you into phase 2. We are now into the summer months. It's July, and this will take us through July, August, September, and October. What's happening with the pandemic at this time is that we're starting to level off on cases. Things are seeming to be a little better under control. PPE supplies are less strained. Testing has become more accessible. They're talking about people getting at-home testing and being able to do point-of-care testing and rapid testing. Hospital surge capacities have improved. Community lockdowns have ceased. But we are expecting a fall surge. And the influenza season is quickly approaching. And for those of you who work in long-term care, you know that October 1 is a big day for us because it's the beginning of influenza season. And that's always a difficult time of the year for us with our aging and frail population in the nursing homes and assisted livings. Increasing pandemic-associated costs for all healthcare facilities. And at this point, we're starting to hear that there will be vaccinations coming, and there's a vaccination program that Maryland is planning, but we don't have any idea what that's going to look like. Next slide. What's happening at Charles E. Smith Life Communities at this time is we begin to do weekly testing for all our team members that work in the nursing home buildings and in the assisted living buildings, just so that we could screen effectively in addition to our daily screening tool for everyone. We were also taking staff temperatures every 8 hours. We were testing our residents every 8 hours for vital signs. And we did PCR testing once a week for every staff member that worked in our residences. In October 8th, COVID-19 testing was required for all partners and vendors coming into our residence. As you can imagine, our residents are not able to go out for a lot of their healthcare needs. So we bring all of those ancillary services to them, to their rooms. So X-ray, lab, ultrasound, consultants, therapists, anybody from the community that needs to come in to provide services had to be tested for COVID-19 before they were allowed entrance into our residences. By mid-October, the state had also required that our reporting be more frequent for cases, deaths, any other infection disease-related issues that we were having, both to CMS and to the Maryland Department of Health. I wanted to show you this graph here. Of course, we were looking at this on a daily basis in the COVID Command Center, but these were the confirmed COVID cases across the U.S. in nursing homes. You can see that by the end of May, we were up to almost 9,000 cases across the country. And then weekly, you see how it decreased, but then increased. In the summer months, it leveled off. And then we expected a spike would be coming in the fall, which, as you can see from early October on, it kept increasing. And we were still in the high 7,000 cases weekly for cases in nursing homes. The ongoing community concerns during phase 3 here, which is now October through January. We're getting through the pandemic, but it's a long, long haul. We know that holidays are coming, and there's fear that families are going to get together. And we know that when people are together in closed spaces without a vaccine, there's a high potential for transmissibility of this very virulent virus. So that had us concerned, though we still had not opened our doors, and we were trying to keep the community out as best as possible. Testing frequency increased for our nursing homes as cases begin to rise very quickly. But now we also have treatment with monoclonal antibodies, which we could do in-house at our nursing home and not have to send our patients out. So that was a plus. And there was still uncertainty about vaccinations. I should add that our doors were closed and we were not allowing visitors. However, we did allow end-of-life and compassion care visits with permission from our team so that families could come in to see their loved ones who met that criteria. By mid-October, the preparations for the fall COVID-19 surge were enhanced. By mid-November, we opened our COVID-19 observation unit. So this was to accommodate new admissions coming in from the hospital, which we get quite a few on a weekly basis. We didn't want them together with the rest of our population because we had to observe them for signs and symptoms of COVID-19 and make sure that they didn't transmit it to our staff or to our other residents. So we established a COVID-19 observation unit where new admissions would go for 14 days under careful observation of the physicians and the clinical staff. Almost by Thanksgiving, weekly testing of our residents began. So now we were doing approximately 500 tests per week of our residents living in the nursing home and the assisted living at one point, just to screen and pick up any positive cases and get those under control as quickly as possible. Next slide. Testing for our Hebrew Home associates increased to twice a week by November 23rd. Again, this was in anticipation of the Thanksgiving holiday and gatherings. Obviously, our staff doesn't live at work, and so we know that they go out into the community and come back into work. The fear was that the virus was increasing in the community and would come into our residences. So we decided to test everyone twice a week. Again, increased reporting requirements to state and federal agencies. And by mid-December, we were beginning preparations for our vaccination clinics. Next slide. I wanted to put this here because, again, those of you who work in long-term care know that this is one of the most highly regulated healthcare sectors in our country. We are subject to a lot of governmental inspections, most of them, I'd say 99% of them unannounced. And so these were some of the key inspections that happened throughout the year. Again, early on in the pandemic, April, we had the epidemiologist on site who reviewed all our COVID infection control protocols as well as our COVID recovery units and set up for those. May 18th, as I showed you the slide with the picture of the disaster medical assistance team visit. September 23rd, our Maryland Department of Health Technical Assistance team came for an inspection. October 5th, CMS QIO iPro site visit. This is a quality initiative organization that looks at specific infections and infection control protocols in our nursing home buildings. We had a clean collaborative site visit looking at our infection control cleaning protocols. October 28th, the Office of Healthcare Quality, which is our state surveyors, did an infection control focus survey. A couple weeks later, November 17th, the Office of Healthcare Quality did another infection control focus survey. What I wanted to show here is that the government agencies were very focused on nursing homes. And again, because of what had happened in New York back in the spring, nursing homes were being very carefully watched for how they handled infection control protocols and how they were keeping their residents safe. So this was happening quite often. Next slide. Oh, we're getting to the end. This was a happy time for us. We got word that the vaccinations had arrived. And in Maryland, nursing homes were obviously in the first group of those to be vaccinated, both the residents and the healthcare workers working in nursing homes. So our vaccinations were coming in early January, and that's our Assistant Director of Nursing there, Abibu, getting his shot the day that our vaccinations began on January 2nd. Next slide. So here are our vaccination rates as of early June. I think I finished this deck last week, so this is through last week. For our residents living in the Hebrew home, which is our nursing home, and Landau, Cohen, Rosen, our assisted living, we had an occupancy of 442 residents, 87% of which are fully vaccinated. Reminder that fully vaccinated means that they are 2 weeks past their second vaccine, if it was Pfizer or Moderna vaccine, and 2 weeks past the Johnson & Johnson vaccine, if that's what they received. In the independent living, our occupancy of 427 residents there in those two residences, 95% of which are fully vaccinated. And as far as our associates, I am very, very proud of our team to report that as of last week, 836 staff members, 79.5% fully vaccinated. I am positive this is over 80% after today. Next slide. Oh, and just to put it in perspective, when we were in the 70s for staff vaccination rate, the country was reporting about 40 to 50% vaccination rate amongst healthcare workers in our field. So that was amazing that our team came together and received their vaccine to keep our residents safe. I wanted to recap with a summary. So as of June 17th, this is our project tracking smart sheet where we documented all our work from day one. We have 14 in-progress projects at this point, 49 projects that were abandoned, 2 projects that were postponed. But most importantly for our team, I wanted to highlight that we completed 601 projects, which are not one-step projects, but projects that take many, many hours, a lot of work, a lot of effort, and a lot of time by all our team members to complete. So a remarkable feat, and I'm proud of each and every single one of our team members for what they accomplished during this pandemic. Next slide. Another summary slide. By January 2021, just to put it in perspective with a little snapshot here, we had spent at Charles E. Smith Life Communities $2.4 million on COVID-19 related costs. We had gone through almost 56,000 gowns, purchased over 144,000 face masks, 4.7 million pairs of gloves, 15,500 COVID-19 tests for our associates, all of them PCR, which are not cheap. 3,300 training hours were conducted for our associates on COVID-19 topics alone, 90 hours of virtual town hall meetings for families and friends, hundreds of hours of virtual lifestyle enrichment programming for our residents, 700,000 in-suite meals were prepared and delivered because we had to close our dining rooms and we could not do group dining. And I'm going to get into the last part of my presentation with the mental health effects that this pandemic had on our residents and all older adults, as well as their healthcare providers. For our residents, isolation and loneliness was very difficult. We had to close our doors. And so not having visits from their families, we knew was going to take an emotional toll on them and potentially lead to a lot of mental health problems with depression and anxiety. Of course, since we are in long-term care and in senior living, dementia is one of our primary diagnoses that we deal with, and this magnified the isolation and loneliness for our residents. Education and sensitivity for our associates around what was happening with our residents was key, and so we spent a lot of hours tackling that. Our families were engaged from the beginning through virtual visits and through other means of visiting and other methods of socializing with their loved ones. And we were very mindful to have individual activities and visits enhanced by our life and leisure teams so that people didn't feel isolated. Next slide. I ensured that there was very close follow-up by our psychiatry team and our psychology partners so that they would get ahead of this and not let our residents suffer from depression, isolation, anxiety, and everything else that came with this pandemic. Surprisingly, our depression and anxiety rates did not change that much throughout the pandemic. My data shows that our use of antidepressants and anxiolytics during the pandemic really did not rise much. And I credit our clinical teams, our physicians, in-house physicians, and nursing staff with this, who were very mindful to be aware that our residents would suffer mentally through this pandemic. Our in-person visits and large group activities are now allowed because we have opened our doors. And so things have gone back to normal, thankfully. For our healthcare providers, our healthcare workers were heroes from day one. Many of them are on this call today. And I want to thank each and every one of them for stepping up and staying with us through this journey. But anxiety and fear pretty much ruled our days. Every day we walked into work and every day we left work with anxiety and fear, personal and professional distresses, fear of taking COVID-19 home to our families, and not knowing what to do if they developed COVID-19. Coping with our residents' deaths and our residents' loss. Again, our staff gets very attached to our residents. We have longevity in our staff, and so they get to know our residents extremely well. They become part of the family. So this was very hard for our staff. Increased rates of physician suicide, we were very mindful of because, again, this was prevailing throughout the country. Burnout and COVID fatigue. Our teams all experienced this, and so we had to find ways to support them and to help keep them engaged and taking care of our residents. And then lastly, one of the biggest challenges was vaccination apprehension, which was not unique to us, but is prevalent throughout all healthcare workers in the country. And this is my last slide. So these were some of the banners we put up throughout the campus about our healthcare heroes. Our families were nice and did a car parade for all our families, our residents, and for our staff. And that's a picture of that there. Thank you very much for joining us today. I hope you enjoyed our journey through the pandemic. Dr. Kasba and Dr. Misra will continue our presentation, and I wish to thank these amazing physicians from Suburban Hospital for the work that they did at their hospital and for the healthcare heroes that they are. Thank you.
Hi, everyone. Hi, good morning. My name is Sonia Kasba. I'm here with my colleague and good friend, Dr. Misra. We'll be talking to you about a journey for us here at Suburban Hospital through the pandemic. I definitely want to first thank you for allowing us to present today, and I want to thank the audience for taking time out to come today and listen. You know, the last year and a half has been quite a, I don't know if the word is adventure. Journey is really the word. It's been, you know, each and every one of us has been affected by the COVID pandemic. And we just want to share with you what our experience was, what our journey was like, you know, through our eyes. So myself and Dr. Misra will go ahead and sort of tag team through this presentation. Okay, so this is our first slide, and this is actually an interesting slide in that I think most of us, when we think of a hospital setting, the colors that are in gray is what we think about when we think about a hospital, right? So you have providers. We had here at Suburban, we had the ER, we had intensivists, and we had our own hospitalist group as frontline workers. You'd think of nurses, techs, pharmacy in terms of medications and labs. But during the COVID pandemic, we recognized there were hidden heroes, and those are the areas that are in orange here. The whole entire hospital had to come together as a unit, as one. Many of us worked in sort of areas that we normally and traditionally don't work. We had to really shift gears. We had to, you know, connect with each and every of the employees here. There were times in which physicians would go into rooms, as an example. We would take in trays. We would have to feed patients because to limit the exposure for our staff. We had a fantastic environmental service team that had to really turn over our rooms, keep the hospital clean and safe for the employees. We had our leadership team that was very key. I was a member of it as the hospital epidemiologist, as the medical response for Suburban, to really keep our employees safe and also give the best quality of care to our patients. I think there was a lot through the pandemic that we realized that a lot of reassurance had to be there, a lot of communication, transparency, making sure we have enough PPE to protect the staff. Every staff member came in. There weren't staff that said, oh, I don't feel comfortable coming in the hospital. I don't feel safe. None of that happened here at Suburban. So I have to say that the team was phenomenal. We really came together as one, and we always say hashtag Suburban Strong. So this was a common sign that we saw during the beginning of the pandemic. And this was this expanded to the hospital. When the pandemic arrived here at Suburban, it was March of 2020, and it just, the timing could not have been better for the new hospital, or what we call the North Building, to have opened, because at that time we had such an influx of patients. And so we had patients in our North Building, which is our new building, and we had patients in our South Building. We kind of had really a mix. We had to stop our elective surgeries because our volume in our hospital was such that we had to have enough beds to take care of our COVID patients. During the early part of the pandemic, what we recognized, we at Suburban had a significant amount of Latino patients come here, and that's really not the encatchment area for Suburban, but it's an encatchment area for our neighboring hospitals in Montgomery County. And because their hospitals were full, we ended up having to care for those patients, which was not traditionally our patient population here. So we had to extend our language services, became a critical part of delivering care. We also, our colleagues here, Dr. Gill and her team at the Hebrew Home, as one of the largest SNFs that we have patients coming from, we had a lot of patients from all of our neighboring facilities come to the hospital. So that was sort of our first wave. We at Suburban really had to kind of partner up and recognize what our community was through this. Our community is not our patients only, but it's also all of the facilities. It's also patients that actually live outside of our general encatchment area, and it became the county at the county level. So this was sort of a very common, I'd say, sign that we would see. And as you can see, we had N95s, we had N99s, we had PAPRs here to keep everybody safe from COVID. So I like to sort of talk about some of the firsts here at Suburban. Okay. Suburban admitted the first COVID patient within the Hopkins system. We were the first hospital in the Hopkins system, the county and the state, to implement cohorting. And what that means is we decided to have certain floors. So originally we had our 6,400 unit had our COVID patients as well as our ICU. So we recognized the importance of cohorting these patients. And this really was important because it kept our staff very safe, our nurses and our providers, so that there wasn't confusion in terms of whether I enter this room with PPE or I enter the neighboring room with PPE. And that allowed minimal nosocomial transmission of COVID in the hospital, which I think was critical during the pandemic. We know that other hospitals were unable to do this. We know there was significant nosocomial spread of COVID, but I can say confidently that was not the case here at Suburban. We were the first hospital in the Hopkins system, county and state, to implement stat testing. And that was critical because we recognized the importance of the turnaround time. This was important to deliver the appropriate and ideal care for our patients, but also for keeping our staff safe so we could appropriately triage the patients to negative pressure rooms if they were positive. So we have a PCR-based testing, which is a 45-minute turnaround time. We have several platforms here we've used at Suburban. First was the Cepheid, next was Acula, and then we have something called the BD Max, which is a little bit longer turnaround time. We're also the first hospital in the county to transfer a COVID patient to the NIH. One of the other key factors during the pandemic was to collaborate with our neighboring hospitals. We had to collaborate with our county facilities. We had to collaborate with the NIH, was able to help us take patients when we were sort of at the peak, and also our colleagues at Sibley, and most importantly at Hopkins, to be able to take patients that were critically ill and some that needed ECMO. Sorry, I mentioned these. Okay. Very good. So this is a sort of NIH document, I call it, that kind of breaks down the patients that we saw here. Early in the pandemic, we really didn't have a lot of treatment options. We thought hydroxychloroquine worked. We thought steroids worked. We weren't really sure in terms of the treatment options that we had. But as the journey continued through the pandemic, we recognized buckets of patients, I would say, and that would be the top here is the non-hospitalized mild to moderate COVID-19 patients. And these are patients that were in the outpatient setting that didn't require any hospitalization, where we could give them a monoclonal antibody. And the alternative care site, which I'll mention and talk about later, was a place that we could refer patients. We also recognize the importance of doing webinars and educating our providers in the community, and also our community members, so they could empower themselves to be able to seek the right care that they would need. Our second group there is hospitalized but don't need required oxygen. Here, we would monitor these patients. They didn't really qualify for dexamethasone or remdesivir, but those that needed oxygen or supplemental oxygen will be qualifying for that. Dexamethasone, regardless of date of onset of symptoms, but remdesivir had to be less than 10 days. And these changed actually as we went through the pandemic. This is actually an area of the hospital during a COVID response, a critical care area, which actually moved from the ICU, general ICU, to 2400. Here we could kind of put ICU patients and non-ICU patients, but this is to show you we have our IV poles outside the room so that we could, instead of having significant exposure to nurses where we'd have to, go in and out of the room, this is sort of, you see in the back, you see a nurse with a PAPR. This was actually what we ended up turning our ICU into and how it looked. During the peak of the pandemic, we had anywhere from 80 to 100 patients hospitalized here at Suburban. That was both ICU and non-ICU patients. As I mentioned to you before, our first phase had a lot of Latinos. We had a lot of patient population here that's very educated, understood the importance of staying at home, and didn't require to go to work because many could telework. And during the first phase also, we had a lot of patients from our neighboring facilities. We also thought the importance of providing PPE for them and seeing how we can help implement testing at the facilities. So that was a great collaboration we had with our colleagues in our facilities. During the second wave, which was in the early part of 2020 winter, we had once again a Latino patient population, but now we recognize it was patients, older patients who were at home who had care at home and were being exposed by many of the people who would take care of our patients at their home. And so we continue to collaborate with our SNFs, which continue to be critical during even the second phase of our pandemic. I'm going to talk about a couple points here, and then I'm going to hand it over to my colleague here, Dr. Mistra. But really important during our journey was to understand the importance of patient disposition. I'm going to highlight the bottom four, and important for us was to have a good collaboration with the NIH. They had several studies. They were able to help us transfer patients there so that they could offer treatments that we couldn't offer, and that was very successful. The alternative care site located at Tacoma Park, which is the old WA, was a phenomenal collaboration. This was a facility that is federally and state funded. It was what I used to call the COVID hospital. All the physicians took care of COVID patients, the nurses, and one thing that was phenomenal there that they had physical therapy services every day for our patients, which was critical. So we really worked closely with the alternative care site, transferred as many patients as we could, because as we knew, the recovery time for COVID required a lot of physical therapy because these patients would be quite deconditioned and fatigued. The bullet underneath that is isolation discontinuation. Early in the pandemic, we didn't really know when it was safe for a patient to come out of isolation, but as we went through our journey, we recognized 10 days of isolation for patients who are not complicated or patients who are at home, in terms of keeping them in a place that they are not able to spread the disease to others. And 20 days is for those patients that are in the ICU. We recognize that. The last bullet is about testing. And what we did is early in the pandemic, we realized the importance of testing every admission. That way we had the appropriate diagnosis because we knew that asymptomatic disease was common. We also could triage the patients appropriately in negative pressure rooms. And that way we kept our staff safe and we gave the appropriate treatment to our patients. We also tested, and that's what the bullet is, every 7 days asymptomatic testing because we knew there would be a 14-day incubation period where we would have patients that could test positive later on during the hospitalization, and we didn't want any of our staff to be exposed. And we also implemented testing for all pre-procedures. So every procedure that was done in the hospital or even in the outpatient setting required a COVID test. So I'm going to hand it over to Dr. Misra. Thank you for your time.
Thank you, Dr. Kasba. Good morning, everyone. So, I'm going to go back. Actually. Okay, there we go. Okay, so I'm going to focus on the first two slides. So, as we've talked about previously, it was really crucial to maintain an open line of communication with our skilled nursing facilities. We did have daily COVID social work rounds where we met where the hospitalist on the COVID unit met with the social workers and case management to help to focus on getting these patients, in the hospital and then out of the hospital safely. It was, our skilled nursing facility partners have been really, really helpful throughout the entire pandemic with helping us to kind of keep our patients moving and get the patients who are getting better out of the hospital in a timely fashion. The second bullet point I want to focus on is the home health agencies who we worked closely with and were really a help to us to get our patients who were fairly deconditioned or needed some extended monitoring at home to get them the care that they needed. And one thing that's not on this slide that I want to point out in addition with the home health care companies is our remote patient monitoring program, which was an essential resource for us for those patients who took a little longer to come off of oxygen. And so that was a program where we set up the patients with oxygen and then we sent them home with the pulse oximeter. And then they were able to, they were in touch with a nurse who got their numbers, their oxygen sats, and helped to instruct them on how to wean their oxygen safely. Those nurses were in communication with some of our pulmonologists in the area who assisted us with this program. And so this is just a slide of several pictures of how the community rallied around us and supported us through this pandemic. Community members donated meals and masks and also bought us several PAPRs to help protect us. Other things that our community in and out of the hospital did was, Dr. Kasba may have mentioned previously that the hospitalists and the nursing staff, as the number of critically ill patients in the ICU, as that census increased, we were flexible with them, and a lot of hospitalists and nurses rotated through the ICU to care for those patients. I want to also bring attention to our, notably our CDU, that's 6400, it's our observation unit, and 4700, which is our joint replacement unit. Those, as the COVID numbers rose and elective surgeries were canceled and patients who were observation status or short stay were not coming to the hospital, these nurses, techs, and other staff members rallied to help and quickly converted into a COVID unit to help care for COVID patients. So they were really, really essential, especially in the early days. Next slide. And one other thing that really helped us with preventing burnout was the Resiliency Center, which was set up in the hospital. And it was a place that that all staff members could go. It was available for both day shift and night shift members of the staff, and provided a variety of things. So we had tea, water, snacks. If you wanted to just go sit in a dark room and decompress for a few minutes, that was available to you. You could go listen to music. They also had some stress relieving activities available to us, such as coloring, or they did some yoga sessions, and they had staff members available if any of us needed to talk to somebody about what we were experiencing. Other ways that the community supported us, we already talked about meals and PPE. They made signs that they held up and they posted outside of the hospital. The National Symphony Orchestra came by to give us a quick performance. The Montgomery County Police Department came by to show their support. Another thing, especially in the early days when we were still trying to figure out what we were trying various treatments, we had roundtable talks with one of our infectious diseases physicians, Dr. Agri, where the hospitalists and Dr. Agri met weekly to discuss the latest studies and share our thoughts on what was working. We had care coordination calls with our post-acute partners. We had individual calls with family members and with post-acute partners about the appropriate ways to isolate and quarantine in patients' homes. Suburban also supported its SNF partners by making PPE deliveries. We were able to make PPE deliveries to over 20 skilled nursing facilities, assisted living facilities, and home health agencies in our area in the spring and the fall. So I just want to emphasize, as we begin to see the light at the end of the tunnel, we want to just really encourage you guys to keep it up. So mask, distance, wash, self-monitor. As we see new variants emerging around the world, it's crucial to remember how we've made it this far. I'm going to hand it back to Dr. Kasba. Thank you all.
Thanks, Dr. Mishra. It's fantastic. So just wanted to sort of have a couple slides to sort of close the talk. I think the first bullet there you see is avoid COVID fatigue. I think we can all say it's been quite a journey. I think it was really difficult for us providers to see the number of patients that passed away here at Suburban. It was very tough for the nurses in particular, because they were really at the bedside. More than I would say as myself as a provider. It was very tough to have these long conversations with family members, and the family members couldn't be at the bedside with their loved one, which was heartbreaking for all of us to see. It was, we had to really change the way we practice our meetings. We had a lot of Zoom calls, as we are now. Everything. We also had to, that also kind of led to being able to have support for the family, where they would have video calls with their loved ones. But that's not the same as being at bedside, and we know that. And that's not being the same as being present in a meeting where you can socialize, be around people. I think it's been very difficult for everybody to kind of isolate themselves and not socialize, especially the patient population that we care for is elderly. They're already a group of people that don't socialize as much. Many of them are retired, so they're already at their home. There's been a lot of COVID fatigue. We here at Suburban had daily COVID meetings, sometimes multiple ones in a day. So things have definitely calmed down. We can't let our guard down either. We have to continue to encourage folks to be vaccinated, to protect themselves, so that we can continue to move forward with a healthier and safe life. One thing that we recognized during the pandemic, that if we weren't already kind, it was really important to be kind to each other. We recognized that we had to take care of ourselves to be successful and continue to take care of our patients and in our loved ones. Also, we recognized through the pandemic that we had to make sure that we stayed healthy for ourselves, our family. We exercised, we ate well, we communicated with each other, we were there for each other. There were days that were really tough for some of us who were on the COVID unit to see so many, patients passing away. I think I've never, filled out more death certificates during this COVID pandemic. It was definitely a very tough time for all of us. One other thing during the pandemic, we recognized that the environment in which we were in was very fluid. And what I mean by that, it was, it felt like every moment something was changing. The data was changing. The recommendations were changing. It was quite challenging to stay up to date and be able to communicate this to the staff and reassure the staff, because there were moments that were extremely scary for staff members. And so it was really important for providers to be there, and to, continue to reassure staff. Quarantine versus isolation was a typical terminology at the beginning that was very hard for people to understand and decipher. Isolation is to isolate yourself so you don't get other people sick. Quarantine is for you to monitor yourself after an exposure. So these were kind of terminology that we had to continue to discuss, educate, and orient. So where's our future? So our future is vaccinations. That's critical. That is going to be really the way to protect all of us as we move forward. We don't know where the variants are, in particular the Delta variant, how that's going to impact our vaccination. We'll continue. Several studies are ongoing for inpatient and outpatient treatment options. And then this was our mantra: to continue to wear your mask, 6 feet apart, hand hygiene, isolate and test when you're sick. We did a lot of that during the pandemic. People had any symptoms, they immediately had to not come to work because we didn't want to risk any exposure and get tested. And that was really critical in keeping our staff safe. This is a last slide, and I won't read through this all, but this is sort of what we have felt like was our 12 days of the 2020 pandemic, and it gave me, and I won't go through everything here, but I just want to take a minute again. Thank you all for coming and being present on this webinar, and Dr. Mr. and I are open for any questions.
Dr. Gill, Dr. Kaspa, and Dr. Misra, thank you very much. Those presentations were terrific, very informative. I'm struck by the number of times I heard the word hero, and that is completely appropriate. I'm struck in each instance by the references to teamwork. It sounds like that became a theme. And kudos to you and your organizations for the approaches you took and the successes that you had in a very challenging reaction. So we're going to open it up to questions. Our first question is for your team members and this is to each of you, if you would, for your team members, what are you seeing in terms of mental health consequences for them, either during the pandemic or here in the aftermath? Dr. Gill, why don't you get us started?
Sure. Thanks, Jeff. Yeah, great question. So I think it takes a certain kind of person to be in healthcare to begin with. And so resiliency, I would say, is the word that comes to mind. That's just a natural attribute that we see amongst our team members. I think a lot of the fears and anxieties that I saw a year ago have abated. I think the vaccine was revolutionary and life-changing for all of us. I think amongst our teams, vaccination apprehension has really, really improved, and our vaccination rates are very, very high, and people feel safer being at work. They feel like heroes because they are heroes, and I think that their mental health toll has improved. So we suffered, but we all suffered together. I think our teams, as Sonia and Nisha mentioned, our teams banded together. We were there for one another. We created our Beekeeper platform, so we're able to put uplifting stories on there, pictures, everything that's happening amongst the team members. Again, we have over 1,000 team members on our campus, so it's hard to get to everybody personally, but this is, I think it's much better. It's definitely much better after vaccination.
Good, thank you. Dr. Kasba?
Yes, I mean, I'd echo a lot of what Dr. Gill said, and I think one thing, we try to make it as fun as possible, if that's possible to say, you know, we had a lot of pictures, we kind of like, you know, helped each other out, we did TikToks, to kind of, put a smile on everybody's face and kind of come together as a team, which was, I think, really critical during some of the peak times. I have to say, it was our hospital's group in particular, I think, was just tremendous. We had to work extra shifts. We had to help out the ICU because, our volume was just spreading. We had to really work closely with our SNF colleagues. We had to work very closely with our social workers, so we appropriately placed our patients for discharge. So it's really just everybody. I mean, I have never seen in my professional career a time in which every single person in your healthcare facility comes together as a unit. It was, no one ever backed out. It was just this powerful strength I think we had. And we will continue to have, if anything else comes our way.
Dr. Maestra?
Just to echo what Dr. Gill and Dr. Kasbev said, I think, at the beginning of this pandemic, we were all already, the hospitals group was a fairly close group. We spent time with each other in social settings as well. And so really, I feel that we got even closer during this pandemic. And as Dr. Kasbev said, we did try to make it fun. Other things we did, we talked about exercise. We had a suburban Peloton group together. We read books. As they mentioned earlier, we also kept each other up to date on as new studies came out, which really helped us to feel like we were in the trenches together. So.
Good, thank you. Another question for each of you. As you saw more and more people who were victims of COVID and learned more about treatments and learned more about symptoms, how did you communicate all of that information internally with your peers so that everybody would be able to share knowledge? Dr. Gill, maybe you can start us with that one as well.
Sure. I didn't mention in the beginning, but at Charles E. Smith Life Communities, we have our own in-house physicians. So we have 7 full-time physicians and a couple of part-time physicians, as well as a nurse practitioner. We have a lot of nursing staff and a large clinical team. So we used our internal platforms for communication, meetings. Zoom became our new best friend. So a lot of internal team meetings and communication meetings. Our emergency leadership team was meeting daily to operationalize and strategize COVID operations. And then we were communicating that through higher management and directors to the rest of staff. But I think having our regular team huddles, we had daily operation teams as well with all our administrators across the campus. So that helped get the communication out. Obviously, for medical information, I share with my doctors anything that comes across the news, the medical journals and the medical news, just so everyone was up to date. But as big as it is and as spread out as it is with 1,000 employees where we are, we can still get together and see people and communicate effectively. So I think we just used and leveraged the technology that was available to us to get information out in real time. It was not a problem for us.
Thank you. Dr. Misra?
So we had several different resources. So on our electronic medical record dashboard, we started compiling resources there on the homepage for the hospitalists to use. The healthcare system overall developed a set of guidelines as well as we learned more about COVID. That's the Agile MD guidelines, and so we were able to pull that up whenever we had a new COVID patient, and it had everything there. How to categorize COVID patients based on severity, what initial inflammatory markers to order. There was a committee reviewing all patients to see whether they qualified for remdesivir. And so those criteria were clearly laid out to us as well. And then I mentioned earlier in the presentation, but we also for some time had weekly roundtable talks with one of our infectious diseases doctors, Dr. Agri, where we went over what our experiences were like on the COVID unit and what the latest studies were showing.
Thank you.
Do you have
Anything to add, Dr. Caswell?
Yeah, no, the only thing I'd like to add is, we here at Suburban, we had a executive leadership team would meet daily. And Cindy Noto Bartolo was our lead COVID response, and I was the medical lead. One thing I do have to say that was critical through this is transparency. I can't emphasize how important that was to keep everyone up to date every moment of the day and being available for the staff. And we also had Dr. Park and Dr. Hockey, who were our hospital leads at that time, really were very wanted to send out daily email updates, which was very helpful, so that people could know what the latest was, if there were any changes in practice, what our numbers were, is there anything we can do to deliver better care, and that really helped. I think, as Dr. Gill mentioned, Zoom became our best friend. It actually made life a little bit easier, as sad as it may sound. We didn't have to get up and run. We could sit in our offices and, do charts that we have to do, but we could also be very involved in meetings. One other thing that we did, and we collaborated with the NIH multiple times, is to do webinars and outreach, not only to our hospital providers and nurses, but we also did it to community providers. And we also did talks to our community members, and I've done several talks to our foundation at Suburban too. So it was an opportunity to really educate people, so that there was a lot of transparency, not only within the hospital, but outside the hospital.
And here's a related question, Dr. Cosma and Misra, for the two of you. I guess Dr. Cosma mentioned that Suburban was the first of the Hopkins hospitals to have a COVID patient. And I understand that there were reports of airlifting of patients from one hospital to another. How did you work with your affiliates during the pandemic, and how did they help or hinder what you were doing?
So one good thing that we were very lucky is that we're part of a larger system. That larger system was really our backbone and very critical in being able to support us in the time of need when we just couldn't manage the volume. So Hopkins and Sibley, Hopkins in particular, really took patients that we just were at our maximum capacity, and more importantly, the critically ill patients that required ECMO, or we're going to be intubated and critically ill, and sometimes they had clinical studies that they could offer the patients. So we really had to work closely. I have to say, Johns Hopkins was phenomenal. Their support was incredible during this, because we had the largest volume in the hospital. In the health system, so that was critical to us.
Yeah, I have to say, I love the Resiliency Center. That was a great story. And of course, Hopkins took the lead in being the provider of information for the whole country during the whole thing. So in terms of experience from the pandemic, are there things that you do differently as a result of the lessons learned? Dr. Gill, why don't you start us on that one as well?
Yeah, I think that's a great question, Jeff. I think the pandemic has taught us a lot. But I think a couple of opportunities that have arisen is leveraging technology. I think we sort of did things always the same way: in-person meetings, in-person visitations, in-person taking care of patients. And I think we were surprised ourselves with how much we could do virtually and through technology, the right technology, smart technology. But I would say, looking at family visitation, because COVID is just one infectious disease, but we have a lot of other infectious diseases that we have to deal with, influenza being a big one for long-term care facilities. And we never close our residences when we have an influenza outbreak, but perhaps we may in the future. But we can leverage virtual visits. We can leverage telehealth now. We like to do our visits still face-to-face with our patients, and our doctors really don't like to use telehealth. But if we need to, we can. The platforms are now set up for family town halls. I would say that was another big one for us. We can keep our families up to date with communication and latest developments without having to rely on email or phone calls or staff resources to contact people one by one, but setting up these huge 150 participant family town hall meetings with key staff members to give updated information. So I would say saving time by using technology in the future is one of the things this pandemic has taught us on how to conduct our business.
Is the same true for you, Dr. Misra?
Yeah, so I think that technology was obviously a huge thing. One other thing to piggyback on what Dr. Gill was saying about family visitation. So the pandemic has made me realize, especially, I emphasized again the importance of communicating with families, and I saw day in and day out that people were anxious when their family members were not here. Patients were more delirious when they were isolated, and so it made me a better provider. It emphasized the importance of being in close communication with families of my patients. And then from a patient side, or on a more personal note, my grandmother is in a long-term care facility, and so I actually just saw her for the first time in over a year. So now helping my family navigate the part about not being able to visit, we had to see her through a window, helping my family to navigate their anxiety and handling that was also something that made me realize what patients and their families are going through, and has helped a great deal.
Mm-hmm. Dr. Cosmo?
Yeah, the one thing I'd add is I really recognize actually the importance of having a patient advocate. That was really missing because it was really hard to explain how critically ill sometimes people's loved ones were when they couldn't see them. It's much easier when you're present and you can see your mom, dad, brother, sister, husband, wife when they're ill. You can kind of understand, and it'll be easier to kind of explain what's going on medically than trying to explain what they look like or what as when they can't see them. So that was something that I recognized how critical and important that was for patients in particular.
Fantastic. Well, we're out of time, so that will be our last question. Dr. Gill, Dr. Cosma, and Dr. Misra, it's extremely impressive that not only do you bring intellect and competency to your mission, but also compassion, and that's terrific to see. I want to thank our audience for joining us for this last session of the Sara and Samuel J. Lessans Symposium. As a reminder, please look for a survey coming via email and a recording of this presentation also coming via email. Thank you all very much for your time.